Okay, morning everyone. Thanks for joining us. Today we've got Dr. Linda Greenwall. She's going to be talking to us about treating the single discoloured tooth. So over to you, Linda.
Thank you very much. And thank you for the invitation to talk about tooth whitening and the single discoloured tooth. Today we're going to be talking about minimal invasive treatments for treating single discoloured teeth. The first thing to note is that we need to understand the etiology, and I'm going to talk about the difference between treating a vital tooth and a non-vital tooth. The aim of the treatment is to sustain a beautiful, healthy smile with oral health sustainability in a minimal invasive way. What we are in this COVID era, and when we get back to work on Monday, we'll be treating emergencies only. But soon, patients have been waiting a long time to get their smiles improved, and this is on their list. They're very concerned that their smiles have deteriorated during lockdown and they want to improve their smiles. So this is a picture of me in my surgery, pre-COVID, and now this is our standard operating procedure and our protocols for wearing our PPE. A lot has changed, but I wanted to speak to you about tooth whitening because it's a non-AGP, a non-aerosol generating procedure. These are some of the textbooks that I've written on whitening, and I also looked at success strategies for dentists and how they can best improve their practice. And particularly in this time where we're managing crises, the success strategies book has been very popular, and we run seminars on this. This is the practice while it's been in lockdown, and it's changed a lot because of the new COVID safety recommendations with screens and guidance, and we've changed our waiting room into a PPE donning room. As our surgeries have changed, we've blocked out the suctions, the spittoons, we've blocked out, the suctions are still working where we've doubled the speed of the suctions, we've covered over the X-ray machines, and all our consultations now on Zoom, pre-screening Zoom consultations. We did, just a little background about me, I set up a charity called the Dental Wellness Trust, and that's 10 years ago, and we have 4 research studies. So we look at toothbrushing, fluoride, varnish, and fissure sealing, and also elderly oral health are our research areas. Our current research is on safety and effectivity of whitening products, over-the-counter products, and this was our paper published in the British Dental Journal a few years ago about over-the-counter. So as you know, our patients have been self-treating at the moment and undertaking their own DIY dentistry over these lockdown weeks. So some of their patients may have been using charcoal toothpaste to whiten their teeth, concerned about some of the damage that we know about the damage of these materials. And one of the things when we get back to work will be that we're going to need to pick up the pieces and find out what they've been doing for healthcare during lockdown, what damage has been done, and how we need to rectify. So slowly this week I've been returning to work to start practicing, meaning practicing the new PPE rules and the new guidance and the new surgery. And I just wanted to say a few things. Number one, because of the screening questionnaires and the new portals that we've introduced on our Software of Excellence, we are not knowingly treating any COVID patients. They're not COVID positive. Most of the patients, the beginning part was people had the disease around about the 10th of March. And that's been now 12, 15, 14 weeks. Our patients are not COVID positive anymore. Of course, we need to do all the screening, and of course, we need to do all the preparation, but we are not knowingly treating COVID positive patients. I know they say that 70% are super spreaders and we don't know who they are, but we are doing everything possible to keep a safe work environment, a safe environment for our dental teams, and a safe environment for the dentists. And I think there's been a lot of panic in the profession about getting back to work. And we need to consider the professionalism and the realism that we've always approached and adopted for patients in using our PPE and our enhanced PPE. So here is a patient who's been buying the over-the-counter tooth whitening products. She can see that there's abrasiveness, the teeth have lost their luster, and they've been over polishing and scrubbing their teeth, and this is causing damage. You should be concerned about over-the-counter tooth whitening products, and here's our research where we published and we looked at which products are currently available on the market in the UK and the damage that they cause. I wanted to also look at where we are now in terms of our dentistry and aesthetics. So while we've all been sitting in lockdown worrying and panicking about the current situation, our patients' health has been deteriorating because they are anxious, they are grinding their teeth, they've broken teeth, they all need bite plates, but they really want to do whitening. So during the lockdown, we have actually been on our treatment, on our patients of record, who we know and we've been regular attenders, we have been supplying the whitening gel because the whitening gel really helps to heal your mouth. We use it, it's called Oral Health Therapeutic Aesthetics, and we supply the whitening gel in the home trays with the whitening gel, 10% carbamide peroxide. So we were always doing a lot of mechanical dentistry, interventive dentistry, and we'll continue to do that. But what I want to talk about today, not really home and power whitening, but really about the difference between non-vital bleaching and single tooth whitening, vital bleaching, and non-vital bleaching. There are many other maintenance treatments such as enzymatic bleaching, whitening strips, and whitening varnish. But today we're going to be working on talking about non-vital bleaching because there's a whole lot of new techniques that we need to know about. The UK guidelines and the European guidelines are that we can't use more than 6% hydrogen peroxide, which is equivalent to 16% carbamide peroxide, and that is what we place inside a patient's tooth on the non-vital teeth. It can only be sold to dental practitioners, and the first application needs to be at the chase side. So let's go through our protocol. There's also discussion about non-vital, about under 18 whitening, and I'm going to show you some non-vital cases where we had to treat under 18s. So let's look at the patient's factors about whitening, how it's changed. Most of our patients' expectations have gone increased, and so patients seeking whiter and whiter teeth, and there's a philosophy of perfection. Hopefully some patients have realized that life is not perfect. You can't predict pandemics, can't predict life. I'm hoping that our patients and in general humanity have refocused on important values during this COVID crisis, reassessing what is important in life and what isn't, and what are the minutiae to stop worrying about, and really looking at the bigger picture of health, and that we do have our health, and that there are important factors to focus on, and our families, etc. So at the moment there is an age limit for under 18s, but actually we are looking at this year after Brexit actually lobbying for changing that, and I have no concerns about treating under 18 patients if it is relevant for them, and we can talk a little bit about that in the questions. Whitening for Life is a whitening maintenance program, and we've been, during COVID, during the lockdown, we have provided, as I said, whitening gel for patients because it heals the mouth. Carbamide peroxide has been shown to elevate the pH and has been shown to really help significantly with patients' oral health. It also, the elevation of the pH helps with the release of the urea, helps to improve wound healing, improve the pH, improve root decay and tooth decay. So we are using that. And then the other factors which we now know, it's not only 2 weeks whitening, and there are some patients who need to have therapeutic use, these whitening strips, and the power gels are now changed. There's new whitening gels for that. So we need to, when we get back to work, there's a lot of things that we need to reassess in terms of priorities. And yes, we'll be focusing on emergencies for the first few weeks, but there are different versions of emergencies. And what we have been doing is we've been Zooming our patients, and I find that to be the most single beneficial thing we've been doing over the last 2-3 weeks. With my practice manager, myself, and the patient, we're able to triage and also discuss and explain. So I've written a protocol for that. If you want to get a copy, then just let me know. But the Zoom consultations have managed to iron out the concerns for the patients, their current issues, their medical histories can be updated. And I will go through all the clinical things on the Zoom consultation. And once we've understood the nature of the problem for the patient and explain our COVID policies, safety policies, and when they see me, we're going to be dressed with our PPE on, and then it's difficult to talk. We do the talking before, and once I finish my consultation, I leave the Zoom consultation, and then the practice manager and the treatment coordinator can go through the fees, the payments, and patients are all asked to pay in advance for treatment. And also we have a PPE charge, which we are laying on patients, which is £35. That's minuscule compared to the major cost of the PPE, and that's going to continue. And the patients are not complaining about that. They quite willingly understand the difficulties of providing treatment during the COVID pandemic. So our medical history forms have been updated. We've now done, everything is digital through a portal, through a software of excellence. All these, the dental history and social history can be done. The question is how you're going to cover over in the, your camera. So for the first few days, we didn't take any photos, and now we've put plastic covers over and sheeting, and plastic sheets over the camera so that we can still continue to operate. Same with radiographs and same with the shade taking. But really what we are doing at the moment is focusing on emergency treatment. But what is a small emergency to one patient is a major emergency on a tiny piece of broken front tooth to another, where we need to be realistic as to what is actually an emergency. But we need to tackle all these issues. So with whitening, every patient, the rule is that every discolored tooth needs a periapical radiograph. So we need to explain to patients that the whitening gel goes directly into the inside of every single nerve of every single tooth, which is why we need to check that everything's fine. So let's just look at a case history. Here is a patient, a new patient attends the practice, previously whitened her teeth. She wants to whiten now. She's got no symptoms. I can see there's some questions, but I think what I'll do is I'll run through the slides and then we can have a discussion, a leisurely discussion, if that's okay. But please type into the chat also some of the questions. I'm happy to answer questions because it's important to have these debates. Whitening is controversial as always. Working in the COVID era now is going to be controversial. So there's a lot of things that need to be discussed, and we should be able to discuss it. So here's this new patient. She wants to whiten her teeth. She's had no symptoms. She's not happy with the present shade. She did notice an anterior diastema has enlarged and the diastema is opening up and wants to whiten her teeth. So here's an x-ray. And when we take the x-ray, we look and we notice that the patient has had quite a bit of resorption on the two front teeth and also on the lateral, upper left lateral. And I call it the moment of truth. When we discuss this with patients, we need to describe, the sandwich, the good, the bad, the good, and explain to patients. And now we will be doing our treatment planning discussions with patients, case discussions, all on Zoom, PowerPoints and Zoom, so that we can explain things to patients, to minimize patient contact, to minimize patients' journeys, to minimize the patients having to travel. But as I said, they've been working really well. So here we would describe and explain to the patient that we're not sure how long these teeth will last. The patient has considerable resorption, but it's important to take the radiograph because we need to know this prior to starting whitening, because if we don't and we whiten and the patient then goes elsewhere and says, I whiten my teeth, and the dentist takes another x-ray and they say, oh, it must have been the whitening causing this. This is not from whitening. The patient had extensive orthodontic treatment for quite a few years, and we think it's the ortho that actually caused resorption. How long are these teeth going to last? We actually don't know. And we need to be honest with the patient and discuss all options, which in this case may include implants as well. So the patient comes for whitening, leaves with implants, but it's very important that we gently, slowly break bad news to the patient and gently work in a way that is patient can take in this information in a general way. Here is another patient, pain on biting, emergency situation. During lockdown, pain on biting, considerable pain all the time. Tooth looks fine. 2018 x-ray, patient's fractured, the tooth needs an implant. And so when we are doing vital and non-vital bleaching, it's important to understand any preoperative pain because there shouldn't be any, and we'll talk a bit more about that. Here is the patient. So let's look at this radiograph. On this radiograph over here, you can see, here's a story. Have a look at this rubber dam. And here we can see there's some teeth with where the arrow is. This tooth is a little bit more yellow than the tooth next door. You can see it's a little bit chipped and broken. And this tooth is slightly more yellow. So the story is power whitening was done for the patient, and then the patient started home whitening. On the third day, the patient was in terrible pain. The dentist comes in, takes a radiograph, and notices this lesion. And then they do a beautiful root canal treatment. But the point is, should we have diagnosed this before? And my answer is, we need to. So the rule is any discolored tooth needs a periapical radiograph to reduce that. We also know that on the third day during whitening, it's the most sensitive and the most painful. And that is because there's maximum saturation of oxygen inside the nerve. So let's have a look at tooth discoloration and what causes it and the other. So I'm happy if you want to take photos. This is a good photo giving you extrinsic and intrinsic discoloration. Please tag me on Instagram, Greenwall Dental. So let's look at the extrinsic stains. Extrinsic stains, they can remove the stain with a prophylaxis. And many patients have had a lot of stain during this time. They may be eating different foods that they're not used to eating, but many patients have got a lot of discoloration during the lockdown. So the fried food, the oil molecule, penetrates actually into the tooth structure and causes discoloration. So the amount, it's called the Browning reaction or the Maillard reaction. And many patients who eat a diet of fried food have slightly browner teeth. And then there's a difference between coffee and tea is worse than coffee. Red wine is also staining. Antibiotic smoking, for oral hygiene. Now we know about dairy and cheese that causes that for the children, the dairy consumption is linked to the eye and the black stain around the teeth on the upper palatal molars. You often see that, and that's related to dairy consumption. Then we look at the stain inside the tooth, which can be trauma, liver disease, kidney disease, root canal treatments. I'm going to focus on root canal and cements, antibiotics, particularly Roaccutane. Roaccutane is a new trendy drug for acne treatment, and that causes a lot of graying on the tooth. If you look up Roaccutane and FDA tooth discoloration, there's a big report in the literature about the grayness resulting in Roaccutane medication. We know about tetracycline in adults and children causes discoloration. Even amoxil can cause discoloration, and copper. Chlorine in swimming pools, patients who swim a lot can get discoloration as well. Then there's not time to talk about white spots and defects, but there are many reasons why patients have white spots, increasing in white spots, 20 to 40% of white spots. Prenatal, perinatal, postnatal, anything that occurs during pregnancy with the mother, prenatal, perinatal, postnatal can cause white spots. Exposure to chemicals such as bisphenol A and toxins can cause this. And so that's another discussion, but I just wanted to discuss it in terms of tooth whitening. Now let's look about pulpal problems. So trauma, calcific metamorphosis is when the tooth is the official name, and that is for patients who have trauma, but the tooth is still vital. So any pulpal problems can cause teeth discoloration. So pulp necrosis, pulp remains, pulp debris, root resorption and bleeding into the tubules. It's the hematin that breaks down into the iron, and it's the iron from the blood that causes the orange discoloration that you see. The other staining materials are local medications such as endodontic sealer, and AH26 was a very popular one that caused problems. Eugenol cement and the phenols, intracanal medications, restorative materials, temporary materials, all of these can cause some type of discoloration, but they found that the AH26 was the most significant one with containing the silver. So they looked at, there's quite a few studies, which root canal sealer caused the most discoloration, and there's an interesting study about that, but I think most of it is due to the components inside. So in terms of indications for whitening, tetracycline discoloration, all discolorations into superficial stains, age yellowing, fluorosis, antibiotic treatments, nicotine staining, before and after restorations matching crowns and partial dentures. Now, many dentists say, well, I have difficulty in providing whitening treatment. I can't sell treatments. We don't need to sell the treatments. We just measure shades. And these days, eventually, when we get back to normal, all patients should have a shade assessment. A shade, and you ask the patient, do you know your shade of your teeth? And we call it an A3 audit. Every patient has an A3 shade, taken when we look if the patient is lighter and or darker than A3, and it leads to a discussion about tooth whitening. As I said, we've got other priorities at the moment, but for the patient, they are dying to get themselves sorted out. So that may be a priority for patients, whereas we are focusing only on pain. So for example, this patient, whitening will do certain amount, but there's a lot of tooth damage and wear on the teeth, which will need further treatment. So pregnant or lactating women is a contraindication. Surface cracks and fracture lines, very sensitive teeth, excessive restorative work can be difficult. My next webinar will be next week, and we're going to talk about tooth whitening and treating tooth wear. And I'm going to share with you some minimal invasive options to do whitening before, during, or after restorative treatment, and how we do a minimal invasive modified 3-step technique. And so please sign in. That is, I think it's next Thursday, and Tipton Training will send you information on that. Contraindication for whitening would be allergies. Children under 18 is not a contraindication. Main contraindications, patients with unrealistic expectations, and also patients who have undiagnosed periapical lesions. So in terms of the way the whitening works, it's an oxidative process. So please put on the chat any questions, and then I'm happy to answer the questions with you at the end. So I'm going to run through a lot of this information so we get the basic academic information and the clinical information, and then I'm happy to have a chat with you. So basically, we have an oxidative process, and the hydrogen peroxide breaks down into oxygen and water. Oxygen enters the tooth structure, into the enamel, into the dentine, and breaks down the double bond stain molecules. And the oxygen and starts to cause the whitening with an oxidation process. So here is a little video which will show basically how it works. Here the whitening gets inside. Can you see where there's a lot of oxygen inside the tooth? These bubbles, oxygen gets inside the nerve of every tooth within 5 to 10 minutes of gel application, which means it's very essential to check the nerve status of the teeth. One of the contraindications, as we mentioned, if you put oxygen inside this and there's a periapical lesion, the patient can get a flare-up of an undiagnosed periapical lesion. So it's our responsibility to check for undiagnosed periapical lesions. And how do we check for undiagnosed periapical lesions? We will need radiographs and clinical testing, and we'll talk a little bit more about that. Just remember, if we're going to treat a vital tooth, there's a lot of oxygen which remains in the tooth for 2 weeks post-whitening. And this can cause the enamel bond strength to reduce. So we need to wait post-whitening before we do any restorative treatment. So here is another description and a diagram showing the hydrogen peroxide entering the tooth. It breaks down into water and oxygen. The water is released and the oxygen penetrates through inside. So let's look at classification of bleaching treatments. A basic bleaching treatment would be no restorative dentistry required, home bleaching 4 to 6 weeks to achieve a B1 shade. Intermediate bleaching would be some restorative dentistry required in combination with 2 bleaching treatments, 6 to 8 weeks to achieve a B1 shade. The magic number is B1. Everybody wants to achieve a B1 shade. An advanced bleaching case would be some patients with complex discoloration, such as fluorosis or tetracycline, or in those patients who are about to have implant treatment, or those patients who have complex sensitivity issues. I want to talk about sensitivity issues so we can manage these before whitening. This is for general patients who are with vital teeth. So let's look at some basic bleaching cases. Here, this patient had an A3 shade, has a little bit of recession in this area, and we did a basic bleaching case, whitening the upper first. Just remember, in terms of the protocol, always whiten the upper teeth first, because the upper teeth, it whitens quicker, there's less sensitivity, and the patient's got a color comparison. Then we would introduce the lower after 2 weeks. So we would do, the protocol is overnight whitening, upper tray first, 2 weeks, review the patient, and then the lower teeth. Then the lower teeth take a minimum of 3 weeks overnight bleaching. Using 10% carbamide peroxide, that is the best way according to the research, and has shown to be the most predictable. This patient smokes and has a lot of fried food, hence the discoloration. And this is the result. All of these are 12-year results where we followed our patients through. You see the amalgam stain doesn't change. So that's important to explain this to the patients. This patient has got gray discoloration, and although it was gray, it was still a basic treatment, bleaching treatment. Gray teeth can take longer. Those patients who have a C3 shade can be longer. This is an intermediate treatment classified because you've got home bleaching, plus you've got non-vital bleaching. This patient had trauma to this tooth, and you can see this is non-vital, this is vital. Here are the cracks on the tooth. So during whitening, we underdid non-vital bleaching plus home bleaching for this patient. This patient had trauma to her teeth. She had to take a lot of iron tablets because she damaged her liver and spleen in the road traffic accident. As a result, the teeth were very gray, and so we put it into the intermediate category of whitening because we knew it would take longer, and therefore more gel, more time, and therefore the treatment's different, longer treatment time and more expensive treatment. This patient has gray discoloration, and again, we put it into this gray-brown here on the molars, on the canines, and recession in these areas. And so for this patient, it was intermediate bleaching because it needed to be prolonged, and we needed to manage the sensitivity. These days, in these areas, we would cover this all over with glass ionomer. Now, an advanced bleaching case like this, patient has got several discolorations, brown, yellow, orange, white markings. With this patient, you need to tell the patient it's going to be 10 to 12 weeks of whitening. May just first, as I said, the upper teeth and then the lower teeth. This patient, first of all, the brown goes first. Always the brown discoloration is removed, but we never say that. We say to the patient, we're not sure how it's going to be, but brown is the first shade to go away. Then it's orange, then it's yellow, then it's the white spots. The white spots, a lot of them during the 10 to 12 week period of whitening, these white spots can fade as well. And so we have the approach to see what can whitening do for this patient. And we continue for this 10 to 12 week period to see how much of the white marks can be reduced before we would do any resin infiltration or microabrasion. And here is the result over here. You'll see a beautiful natural smile. The teeth are glossy and shiny. After this treatment, we did microabrasion, and the final thing we did using 6% opal luster, and afterwards we polished with ACB tooth mousse, and that gives a lovely shiny, minimal invasive result. And there's a whole lot of debate about AGPs is a high speed or slow speed, but we won't get into that. But this was polished. Here we were polished with low speed, the slow speed, to get a nice even result. Now let's look at the research. And this research from Dr. Soran Kwan looked at the pattern of discoloration. And she noted to penetration, they'd stained the teeth with rhodamine B dye, and they noticed that the penetration was accentuated in an existing crack line. Now, this is relevant to us because the whitening goes straight into the weakest part of the tooth first, a defect, a porous area, or a crack, or as we said, the undiagnosed periapical lesion, it goes into the nerve within 5 to 15 minutes. So therefore, we need to look at cracks as an issue and decide, is the patient a bruxa? Does the patient have a cracked tooth syndrome? And what is the issue? Because if the patient does have a cracked tooth syndrome, that may need to be treated prior to whitening. The discoloration and the whitening pathways are very similar. So here is a stain. Hydrogen peroxide travels into the weakest part of the tooth first, into the crack, and we need to make sure that we manage and monitor these. This is the research study showing the stain, the rhodamine B dye, in the peritubular areas of the dentine. Now let's look at the general, what is available in the UK. We have 3%, which is called enzymatic bleaching, 3% carbamide. We published an article with my son Joseph on carbamide peroxide and its oral health benefits. And particularly during this COVID time, the use of carbamide peroxide as an oral health treatment is particularly important. And that means we will be supplying our patients with gel using either 3%. This is a product called Whitekin, and it uses a toothpaste plus an enzyme called, which is lactoperoxidase. and combining the 3% carbamide peroxide with 5% lactoperoxidase, it speeds up the reaction, but is like a toothpaste to improve oral health. Then there's Novon Mild from Optident, and that is 5% hydrogen, 5% carbamide. Very useful for sensitive patients, for children, patients under 18 who need whitening, patients who are super sensitive. All of these are very useful. Their desensitizer is tripolyphosphate, which is often in many toothpastes. The basic products are 10% carbamide, and most of the time we would use that. Then we would use 16% carbamide for non-vital teeth, and we'll talk about how we place it inside the tooth, or on a single dark tooth, we would use 16% carbamide peroxide in the specially made bleaching tray. If you're going to use a hydrogen peroxide product only, that's a day product, that's 3% or 6%, that's Polar Day. This is the SDI product, which is Polar Night, 10 and 16%. This is one of the highest sales in the UK is Polar Night. Now, let's look at the other hydrogen peroxide products. So 3% hydrogen peroxide, then you get the bleaching strips, then you get 10% and 15% Tray White Supreme. You can't use those because that's over the limit, but 6% hydrogen peroxide are in these products here. What is the difference between carbamide and hydrogen peroxide products? Hydrogen peroxide only. So these products, hydrogen peroxide only, that means all the oxygen is released within half an hour to 45 minutes. They don't have any benefit using them prior to that. So let's go back to this. Carbamide peroxide, the benefits of carbamide peroxide is that it contains carbapol, and carbapol is a slow release oxygen agent whereby the oxygen is continued to be released all the way through the night for 10 hours. So for home whitening and for non-vital bleaching, the benefits that it keeps going for 10 hours is really useful. Continuing, the added benefit, it contains urea. Urea helps with wound healing, with soft tissue healing, and with gingival healing as well. So those are the benefits. The urea elevates the pH and helps with the root decay and tooth decay. So that is why we like to use carbamide as a therapeutic treatment. So we mentioned the hydrogen peroxide only product, and you can use, for example, 6% hydrogen peroxide as a non-vital bleaching technique in the outside-inside technique. So we need to assess pre-sensitivity, we need to assess patients for sensitivity. And again, we'll be triaging about sensitivity versus toothache, and we need to examine that. So we need to look at our desensitizing toothpaste, and the research has shown using the desensitizing toothpaste 2 weeks prior to whitening is effective. And whether we need to do any restorative, we do a lot of covering over of lesions, where the class 5 lesions where patients been scrubbing, brushing too hard during the stressful time. Resin modified glass ionomers is our treatment of choice. So we ask the patient, and we still be asking the patients 4 questions. Do you have any sensitivity to cold? Do you have any sensitivity to heat? Do you have any sensitivity to sweet? And do you have any pain on biting and sensitivity to cold? Sensitivity to cold means that there may be some gingival recession. Sweet, obviously there's decay somewhere, and we need to look at that. Does that matter during whitening? Not really. It depends is the answer, because we need to see how severe is the lesion. Then sensitivity to heat, that means there's a pulpitis on one tooth, and we need to take that into consideration. Really important that we look at that. Pain on biting and sensitivity to cold is a crack. So we need to decide where it is, determine what the pre-treatment is, because this will be what we'll be triaging now. We will triaging all these problems now. So is the tooth, is it what we need to determine, is it sensitivity or is it an actual toothache? And that is what we need to determine now. When we are doing non-vital bleaching, there should be absolutely no pain. And we need to pre-treat that and assess it. So pain on biting and sensitivity to cold, actually there's a syndrome when they bite ice to this extreme level. I can't remember the name of it, but there's an extreme syndrome on this. Pain to cold things, we need to examine that. The chocolate eating, we need to look at that sensitivity, and the heat. Pain to heat, we need to examine. Of course, it's really important to have a discussion about whitening and the shade, and what is the shade the patient is trying to achieve. And we can talk afterwards on the questions and why non-vital bleaching may not be as predictable as home bleaching. But this is the new shade guide by Dr. Radha Paravina from the University of Texas. Excellent textbook, Quintessence Textbooks, Fundamentals of Color with Stephen Chu. But we're looking at the shades. When we're making veneers in 1M1 and these shades here. Patients want to get to this level with whitening, and this is a scientific measure. This is a value shade guide here, and these are the shade numbers in value shades. So if a patient goes from a 4M2 to a here, the 1M1, that is a huge amount of shades, 21 to 5, that's 16 shades. So that's quite very beneficial. Then we needed to look at where is the enamel. Where does the bleaching occur? Does it occur in the enamel or does it occur in the dentine? Here is a study showing there's significant whitening in the enamel. We didn't know that, and this study was published in 2011. We thought it was only in the dentine. So when we're whitening non-vital teeth, we're bleaching root dentine as well. So we need to look at the time and the process, and why it takes long is because we've got to bleach out the discoloration medicaments inside the tooth. So here is a young boy that we treated doing a he had severe white lesions on his teeth, and we did home bleaching for him. And again, we can talk another time about under 18 whitening, and this is our article on it, and the 10 categories for whitening under 18s. So let's look at single discolored tooth. Which of the teeth is vital and which is non-vital? Obviously it says over here that they look the same. Here is a discolored tooth. This discolored tooth is from trauma. The tooth is still vital. We need to make a sectional bleaching tray. And then the way that we make a sectional bleaching tray, I'm going to show you the design. This tooth is non-vital. This was during ortho. This patient had trauma, and all of them, it's the same protocol with a few different measures. This is a vital single tooth treatment. When we are doing our treatment plan, we need to discuss, number one, are we going to bleach just one tooth, or are we going to bleach the whole lot? My understanding and my treatments is that we should do all the tooth whitening. You start with the dark tooth first, and you make a sectional bleaching tray, followed by the full upper tray. So I'm going to show you the slide design of how we make a sectional bleaching tray. You can't just whiten everything. If you whiten everything in the beginning, this tooth doesn't change as much because of the complex anatomy of the secondary and tertiary dentine inside. So we make a sectional bleaching tray, bleaching only this tooth first for 2 to 3 weeks. And as we see the color lightening, we then whiten all the teeth. We change over to a full arch bleaching tray, and then we make a lower bleaching tray as well. Here is a radiograph. You can see the trauma that has occurred, obliteration of pulp chamber and pulp canal, no need to endo. This is calcific metamorphosis. It will take a long time. It doesn't just whiten within 2 weeks. It can take up to 6 weeks to whiten. So this is the process of whitening with calcific metamorphosis. The timeline is over 6 weeks. It can, as I said, it takes long because the oxygen molecules has got to penetrate into the tertiary dentine, into the secondary dentine in order to whiten the tooth. Here is another example of a vital single dark tooth. Patient was offered a crown. Patient was offered veneer. Patient said, no, thank you very much. I would like to whiten my tooth. So we made a sectional bleaching tray. Here is a full arch normal bleaching tray. And what we do, and I do this at the chair side, I will mark the dark tooth with a Sharpie's pen here, and I will cut the teeth on either side to make a sectional bleaching tray like this. This is a sectional bleaching tray. We bleach just the dark tooth, and we continue. We can whiten those during the process, but we really want to focus on the dark tooth. And then, as I said, we change over. So here is the process of whitening as the tooth scleroses with the secondary and tertiary dentine. So starting off, what I order from the technician, or we make it ourselves, is 2 upper bleaching trays. I will then mark with a Sharpie's marker, and so I cut off. You see I've cut off over here, and I've cut off over here on either side, the adjacent teeth, so that they cannot whiten at the same level, because otherwise these teeth whiten quicker and the dark tooth looks worse. The whole discoloration looks worse. Here we are marking it and cutting it, and here is the final result. And then this patient will top up every 3 years because of the trauma to the tooth. It needs topping up every 3 years. They use the single arch tray first and the single segmental bleaching tray, and then they go to the full arch tray. So let's look on non-vital bleaching. Indications would be discoloration from pulp trauma, discolorations that do not respond any other way. That was a technique by Abu Ras, which was called intentional devitalization. It was published in 1982. We don't use that technique anymore because we have minimal invasive ways to treat this. And then also stains and discoloration from dentine due to endocelia. Again, these are indications for non-vital bleaching. So contraindications would be inadequate root canal treatment, patient has symptoms or pain from the root treatments, untreated caries, untreated abfraction lesions, insufficient coronal tooth structure, existing tooth fractures, horizontal or vertical fractures, where there's poor prognosis. So you need to say, when you see a non-vital tooth and you're assessing it, you need to discuss with the patient the fact that they have existing fractures, if it's a long vertical fracture or horizontal fracture, that they still may need protection, they still may need a crown, or the tooth needs to have a bite guard afterwards. But you need to explain and show the patients any vertical, horizontal fractures on non-vital teeth. As you know, these teeth are more brittle. Any defective restorations need to be looked at. Patients with unrealistic expectations of the success and outcomes of non-vital bleaching are contraindications. It's up to us to reduce massive over expectations on the results and to be realistic about what results can be expected. On non-vital bleaching, often it can be unpredictable and not long lasting. We can discuss that in the discussion, but the point is that we need to be realistic with patients. It's much better to be realistic than say, oh, it's going to be perfect when it's not. Patients who've had amalgam in metal in the access cavity, again, there's a graying, plus there's the trauma, plus there's the root canal sealer. It may be difficult to whiten. The longer the patients had the discoloration on a non-vital tooth, the longer it will take to whiten. So let's talk about classification. Materials that we are using are 10%, 16%, and carmine peroxide, or 6% hydrogen peroxide. In terms of classification, the new classification is sealed in technique, inside outside technique, open, outside inside open, or outside inside closed. Outside inside open is the you leave the access cavity open and the patient places the gel at the back of the access cavity, and you have a sectional bleaching tray. I use outside inside closed. I prefer it, so I seal in the bleaching material, and I give the patient a bleaching tray as well. We cannot use the following materials: 35% hydrogen peroxide. We can't use more than 6% hydrogen peroxide. Products such as superoxal, where there's 100% carmine peroxide, we cannot use. We also cannot use sodium perborate, because that has phytotoxic and cytotoxic effects, and that's banned in Europe as well. So the old technique used to be using 35% hydrogen peroxide in combination with sodium perborate. And when you use those two materials together, that becomes like using 50% hydrogen peroxide inside a non-vital tooth, which may have previously been traumatized. Not a good idea. So we stick to these materials: 10%, 16%, and 6% hydrogen peroxide. So let me see if this video is going to work. Okay, so first of all, let's look at what is involved and the stages and the protocols. Number one, assessment. History. Does the patient have trauma? Is there previous infection? Does the patient have any pain? We need to do a clinical evaluation. The clinical evaluation will be tapping pain, pressure pain, palpation, and understanding when was the root canal completed. Because if it's recently been completed, then there may be there's a little bit of tapping pain afterwards, which will settle. So we need to evaluate that. When we look at the radiograph, we need to look, is there a lesion? Is there no lesion? What is the quality of the endo going to is? What is the quality? Does it need to be redone? Is the GP condensed, or is it sparse? How much clinical crown is there? What are the restorations inside the tooth? And what is the crown root ratio? Look and see if there's enough label enamel to bleach. So all these are the considerations which we need to decide. And then we need to look at clinically what is involved. Number one, we've got to do a consultation. And as we said, these days, a lot of the time, the consultations are on Zoom. I'm absolutely loving these because it actually speeds up the clinical time because we've got the whole story, the history, and what's happening. X-rays are essential. We need to use the X-ray to look and do an assessment of what is the status of the endo. Then we need to make a diagnosis, and always giving a differential diagnosis for all patients with different options for treatment. We need to plan the treatment and plan the clinical treatment. We often may need to redo the root canal treatment, wait a month for this to settle, impressions for bleaching trays. Then we would prepare a barrier where we cover over the gutta percha. First stage whitening dressing, second stage whitening, and third stage. How long is all this going to take, you may ask, and I'd be very interested to hear what you have to say about this. And then we have a final restoration. But this is quite a lot of time, and we worked out possibly it's about 6 hours of clinical time. So therefore, what is the fee? Because when we discuss this with dentists, they often go, oh, no, how much should I charge for non-vital bleaching? About £51 a go. Seriously? How come? And you go, well, £51 is a nice number, but if you look at all these protocol of everything that needs to be done in 6 hours, that's not going to touch sides. So we need to read these days, during and after and in the middle of this pandemic, we need to look at what have we learned as a result? What are the good things we've learned during this pandemic? What are the important values, and how are we going to practice dentistry differently? Because what we have noticed now is the preparation time is hugely increased. The admin is hugely increased. But the benefit of the preparation and the admin time being hugely increased means that we are much better organized, we are not going to run late, and we can get on and do the clinical dentistry that we've always loved. And colleagues, you will see that when you get back to the chair side to do your treatment, you will all calm down. There's a massive fear of dentists going on at the moment. There's fear and panic. There's fear from the patients. There's fear from the dentists. There's fear from the dental nurses. And we all need to be realistic and common sense and just calm down and do the best that we can. So here we are removing the dressing, and we're changing the dressing. Here we're packing the gel inside, and it's just showing that's not a good video. And here we're placing inside. I'm going to just show you a photo of this. Can you use endoperoxide? Answer is no, it's over the limit. The limit is 6% carbamide peroxide. If the patient has had trauma, can we do non-vital bleaching? We need to be very cautious. They did a very good study, Sveck and Linfield, in 1985 about the amount of trauma associated with cervical resorption. And this is when they were using the technique 35% hydrogen peroxide with sodium perborate. And they noticed the trauma was linked to cervical resorption more than the materials. But these days with the products that we're using, we don't get it. Now, I'm not sure if you can see this photo. There is a long vertical crack here, and there is a long horizontal crack here. So this patient, we did non-vital bleaching. He's ground his tooth. He had trauma to the tooth. And we need to, I'm going to run through that, but we need to give the patient all the options: whitening, bonding, veneers, crown, post-crown, etc. on these non-vital teeth. Step by step evaluate. We mentioned what we are going to do. We'll talk about placing a barrier, and I'll show you the technique on that. And then the final palatal restoration. We need to decide what is going to be the final palatal restoration. We spoke about case presentation. Financial. Now, what is the final palatal restoration? I mentioned to you that we have a lot of oxygen inside the tooth after bleaching and non-vital bleaching. So the common mistake that dentists make is they go straight away after finishing non-vital bleaching and place a composite restoration. That means that their palatal composite restoration is going to be leaking pretty soon, and you can get shade regression on this. And so immediately after doing non-vital bleaching, you place either a resin-modified glass ionomer or chemically cured glass ionomer. But actually, most of the time, I use a resin-modified glass ionomer, bleach shade as a final restoration, and that's the end of the story. Don't have to go back and put in a composite restoration. So these are your choices post-operatively: glass ionomer or composite, or resin modified. I like resin modified. You can later on, 2 or 3 weeks later, go back and put a composite on the palatal. But honestly, the resin modified glass ionomers at B1 shade, there's one from Reverb, which is really excellent, SDI, and that's fine. So here we're placing the tray as we showed you. Let's look at this radiograph. The radiograph here, it's a little bit confusing on the periapical area to see, is there lesion, is this a secondary canal over here, should this be redone? And the European guidelines are very specific for the endo: redo it if there's questionable status, questionable prognosis. So step 1, we assess the existing endo. We decided it would be better to redo. When we put in the file, we noted here that there was, from a different angle, there's actually a bigger lesion that we were aware of. Here's a beautiful root canal treatment completed by Dr. Jude Ferreira. Nice solid obturation. Here he's prepared the barrier, resin modified glass ionomer, into it's supposed to be called a bobsleigh design, so that it follows the dentinal tubules. And here is sufficient space for the whitening gel, followed by a dressing, which is glass ionomer. I'm going to run through that with you, but the barrier should be, the rule is the barrier should be 2 millimeters below the CEJ, and it should be at least 2 millimeters thick to cover over the gutta percha, so that there's protection of the gutta percha, because even though it's beautifully well condensed, you can still get whitening gel percolating all the way through, causing irritation, which may happen. Here's our paper which we published on the safety of whitening, and published with Dr. Yemen Lee, whose research is all about safety of whitening, from the University of Loma Linda. That was published in 2013. If you want any of my articles, please go onto lindagreenwall.com and resources. And that is the education site where we have all my articles are there for download. We also have articles for the hygienists on whitening, and all the publications you can download from there. So the European guidelines, it says teeth with inadequate root canal fillings with radiological findings or developing persisting periapical periodontitis, inadequate root canal, redo it. So here, this particular patient, there's debris inside the root canal, there's gray stain. We don't know if the whitening is going to be even, whether there's going to be some marking, and that's important for us to discuss. With this patient, when you look here, they've got missing laterals, they've got other occlusion issues, the other things, but for that patient, they just want the white tooth, the tooth whitened. This is a beginning of an aesthetic discussion, so it's a good start to do the whitening. From there to there, using the sealed in home bleaching technique. So now we would place over our barrier. So the one way is that if you're doing outside inside technique, you place your barrier, you place the gel, you show the patient how to use the impression, how to use the tube of whitening, and they place it inside the bleaching tray. They say you're supposed to have the little pellet where you take it in and out. I think it's very difficult to take the cotton pellet inside and outside each time. So on the outside, inside open, you would start the procedure on a Friday afternoon. You leave the access cavity open. You make a bleaching tray, a segmental bleaching tray for the patient. Every 2 hours, the patient puts in 16% carbon peroxide, and they return to your office Monday morning, and you seal this access cavity. Leave it for too long, and make sure that the patient you select to do the outside-inside treatment comes back for your final restoration, because I have found sometimes they don't take that, they're not quick. Otherwise, I would seal in the gel, and then I would make the bleaching tray to place that. So let's have a look, please. Let me know if you can hear me. It says the internet is unstable. Here is the non-vital tooth. Here, from ortho, here we whitened the tooth. First the dark tooth, then we whitened the upper, then we whitened upper and lower together. I'm sure that you'll say that it was a nice result, and we can all achieve that, but we need to know that we need to know the timing for this. So here is the final results, improvement in oral health as well, and a lovely shade maintenance from here to here. Single from here to here. So how do we place a barrier? We measure the length of the clinical crown. Let's say that's 10 millimeters. We need to go 2 millimeters below the the CEJ, and the barrier needs to be 2 millimeters in thickness. So actually, we are meters for our barrier. We prep in place, then we would place the cover over resin modified glass ionomer, seal it over, shape it into a bobsleigh design, place the 16% carbamide peroxide, then a little bit of Teflon tape, GIC over it, check the occlusion, wait 2 weeks. Patient is whitening inside and outside using 16% carbamide peroxide. I think this video show how to cut this. I'm just going to show you how to do this now. Measure it here. And the gutter perches to 2 millimeters below. And then we prepare that, the barrier. Then we have enough space for the gel. It's actually 16% that we would use. And then we would cover over with the Teflon tape here and a glass ionomer. Here is just a design discussion. The design is the barrier design, it's a bobsleigh. Here is the thickness. It can be 2 to 3 millimeters below the CEJ, and normally 2 millimeters, and there needs to be sufficient space for the whitening gel. The intracanal dressing Medicaid times, you change it. Basically, every 2 weeks, patient comes back, you review the situation, you change the carbamide peroxide inside, and they continue to use 16% carbamide peroxide on the dark tooth. And then you can swap over when they're bleaching everything to 10% carbamide peroxide. And you review the situation. Professor Van Hayward says, actually, you don't often have to do the dressing changes. You just review the patient and they continue with the 16% carbamide peroxide. What you do here is what I do with these bleaching gels. I change the syringe tip and bend it so that it can fit in nicely. And I backfill it so that we can get that nicely condensed. Then I use the PTFE or prep specially prepared, and we plug it down and then place the glass ionomer. Here's a lower tooth. We're doing the same thing. We're preparing with the Gates Glidden drill. Once we've got prepared the glass ionomer, we use a endo plug-up to plug it down firmly. Here we're putting the gel inside, and then we close it up like that. When they come back to when the patient returns, just check there isn't excess material. Make sure when you go into the access cavity, you clean out all the debris on the first time to prepare it. Let's just look at a few cases, and I'm going to here. What is wrong with this? What can you see? The patient has had whitening before. What is the problem? The problem is that, number one, why is there the gray mark here? The reason there's a gray mark here is that the barrier, when they did the non-vital bleaching, wasn't placed deep enough. The barrier is over here. So when I looked at that, it was a little bit of a heart sink moment, because I realized I had to go below the CEJ, 2 millimeters below the CEJ. This can also happen if you've done non-vital bleaching, the patient's gums recede, you may need to go back. And it's really tricky to take a fast hand piece to go underneath here to bleach, to prepare everything for this area. So this is what I'm trying to show you. What is the point of just bleaching one tooth? Which tooth is it going to match? Because it doesn't match any of these teeth. So you have to go back inside, go 2 millimeters below the CEJ. And here's the result. Re-whiten the teeth, re-whiten the upper, and then we re-whiten the lower. Here again, there's the roots showing. These two are both non-vital teeth. Patient's got root decay. We need to look at all the options: internal whitening, sealed in bleaching, just external bleaching. And often one option is just external bleaching without going inside. That is an option. And in this current climate where we're only doing AGPs and non-AGPs, perfect for whitening, absolutely perfect. So you don't have to go inside the root canal. You can bleach from the outside, review the situation, and that is perfectly fine. Or you can just do bonding onto the tooth, but all this needs to be discussed with the patient. Here's the endo, here's the single arch bleaching tray, like that. Afterwards, we whitened these two. Then we had to do some composite bonding to improve the shape and the shade. Nice results. This particular patient, we started like this over here. We built it up, etc. I want you to see this crack on the tooth there. Patient was playing rugby, and he actually cracked and broke this whole tooth off. We've just placed an implant and uncovered. Going to do the final restoration. So this is what I'm saying to you. You need to tell patients if they've got any cracks like that, that further treatment may be necessary. What I wanted to show you here is the weak access cavity. It's open and there's defects inside. And this is why you get the discoloration. Make sure that your access cavity, when you seal it with the final restoration, is well sealed. And that is why, again, we can discuss the regression and why these regress, but there are several reasons why. And this was followed up by a Michigan splint for the patient to protect the tooth. With this particular patient, she's a young girl of 11, discoloration. I thought, well, she's a little bit young. What I'll just do is I'll put some composite over here, maybe do a little bit of bonding over the time. When I did the clinical examination, she had a large palatal lesion with pus at the back, and they reported that root canal was treated a completion a month previously to doing the X-ray. It had MTA and 3 lots of antibiotics. So we went to look at, so here are the clinical photos. We did the CT and we noticed such severe bone loss. Here is the palatal swelling. Here is the results, the widening of the palatal area. This was probably a cyst which needed further treatment. And what are the options? Because whitening is the minor option to the major pathology, which always needs to be treated. And if it was your child or your daughter, what would you do? You can see the extensive bone loss. And so one option would be to extract. One option would be to for surgery. One option, the MTA was difficult to redo. Now, another case with us that we did, here is previous trauma, separated teeth. What we did is we took out the old root canal material. This is how the patient presented, like this, a lot of resorption here. What we did was this is Jude Ferreira, we put in the calcium hydroxide first to let this start to heal up. And here you can see healing of the lesion. And that's all we did prior to whitening. So it's very important to be realistic and say, what is the result going to be? Is it going to be excellent? Is it going to be fair, slight change, poor? We need to be realistic and say, we don't know what the outcome is going to be. We're going to try and get a slight improvement, and we may need to do further restorative, or we're going to do combination of aesthetic and whitening. So all of this needs to be realistic with non-vital bleaching. So here is the young boy I just showed you. That was the treatment. Here with the defect that I just showed you. Here, this is him. And slowly we got a good improvement for the consideration of what's going on underneath on the root canal. Let's talk about managing the problems associated with non-vital bleaching. Color regression is a major. The root dentine doesn't bleach as well, so we're going to need to bleach longer. Gingival recession with non-vital tooth and patients with unrealistic expectations, where this is what we discussed. So the coronal restoration leakage, I just showed you that patient, the age of the patient, access cavity, and making sure that the bleach is reaching the teeth that it needs to do. And sometimes the bleach happens too quickly with very high materials, so you need to do a slow approach to be more methodical. Again, cysts, you need to show evidence of healing prior to do whitening. Here we've had to redo endo to improve that, and then we could go ahead to do this lovely result for this young patient. So coming back, we come to the end now. I'm coming to the end. Sensitivity management during bleaching is the biggest problem that dentists have. So the first thing we want to do is prevent it. This is not for non-vital teeth, because non-vital teeth should not be sensitive at all at any stage during any whitening. And you should not start non-vital bleaching if there's any sensitivity whatsoever. So we want to prevent, we're talking about bleaching of vital teeth and reducing sensitivity. We want to prevent it. We want to treat it, and then we want to help the patients self-manage is the key word, the triaging and all the self-management. We mentioned to you on a vital tooth that the day 3, there's the day 3 rule. It's most sensitive because there's maximum oxygen saturation in this area. And we pre-warn the patients that it's going to be sensitive. Take a photo of this. This is a little table showing you the active treatment and the passive treatment where we can modify the bleaching technique and assess. We use potassium nitrate as a proprietary desoother, desensitizer, the desensitizing toothpaste, and the sensitivity reduction materials. Or we modify. The patient may often be using too much of the gel, and so that needs to be changed. Normally one syringe lasts for 4 to 5 nights if used in a very small amount. It's not the amount of gel, it's the placement with a very tight-fitting bleaching tray. So the soothing materials that are available are normally with potassium nitrate or fluoride, or some of them have got ACP, potassium nitrate, and fluoride. So it works by the potassium nitrate, calms the nerve, affects the nerve transmission, and depolarizes and repolarizes and stops the excitability of the tooth. The fluoride basically acts as a tubular blocker. So this product, Polar Soothe, is a very common product which we administer to patients every time we do whitening. We would give them one of these products. It contains 6% potassium nitrate and 0.1% fluoride, and relieves the sensitivity by using the combination of both of those. So you would, the way that you would use it, either before whitening, after whitening, or instead of whitening. Before whitening, you can place that for an hour a day. For a week before whitening, you can use the proprietary treatments. Very effective. Or they can use it instead of whitening. They place this for an hour a day. So you can do whitening on, soothing one night, whitening one night. Or after treatment to manage any sensitivity. But in general, with home bleaching, you should not have post-operative sensitivity beyond a week. You should be absolutely fine. And it's about contact time is 35 to 45 minutes. So we mentioned all the things we can do, and we spoke about that, how to assess the patient prior to whitening. We mentioned that you reduce the concentration, you reduce the amount of gel, and you can reduce the time that the patient is doing the whitening treatment. How successful is vital and non-vital bleaching, you may ask. The general success rate is 98% or 86% for tetracycline patients, but in general, it's about, with tetracycline, 86% or higher, which is quite significant. So results obviously are going to vary. Treatment time varies. Patients will need to touch up a bit. Normally on non-vital teeth, we would just do outside touching up, outside using their bleaching tray again. Some of those may need every 6 months, using 16%, depending on the discoloration prior, but otherwise every 3 years. So I'm going to stop sharing my screen so we can have a discussion now. And I hope you enjoyed that, and I hope that was helpful. Please look on my website, lindagreenwall.com, to download any articles. Here's my email if you want to email me, and my Instagram. Please tag me on Instagram. I'm going to stop sharing. I hope that was fine. And now let's go to the Q&A. Louise, I see there's quite a lot of Q&A. So, consent form for single tooth and general tooth whitening. Absolutely, I do have a consent form. Email me and I can send that to you. Now, what is the minimum age limit for vital and non-vital teeth for Royal College examinations? Should I stick to 18? No. Okay, so the answer is that if there's a specific need beyond under 18, absolutely we do whitening. And what's the most common age to do whitening is when the child is moving from primary school to secondary school. They're really embarrassed about the discoloration and they want to sort it out. And so we are doing, at that age, it's about 12 years old, 11 or 12, during the summer holidays, we do the whitening because it's appropriate. The child has a psychological well-being from being bullied that is decreased, and we need to be able to do this. Now, let's see, there's some more questions. There's a lot of questions, Louise. So I'm going to try and answer them as quick as possible, or we can open it to the floor. I hope you enjoyed it. Let's just answer some more. Would an OPG sufficient to do a pre-diagnosis? OPGs are okay, but we would prefer to have a, we would actually prefer it to have a PA. So now somebody's asked about whitening for oral health. What I'm going to do, there's so many questions. Louise, do you want to, should we do some live Q&A?
Yeah, there's some questions in the chat. So
I can see there's so many.
Yeah, because we're on a webinar, they can't ask the questions, so they can only
they're all muted. They're all muted. Okay, yes. Fine. All right. So Vishali, some patients find whitening very uncomfortable, especially lower anteriors. Do you know why lower anteriors are so sensitive? That is because their patients are grinding and they have little mini cracks on the teeth, and those cracks and the bruxing is why they have sensitivity. So it's our responsibility to check that over prior to starting. You know, we might need to place soothers onto those exposed lower incisors where there is dentine. And we can, there's a nice product which we use for that, which is called Hurry Seal. And it's a gluma or it's a hema product, which you tap on. You air dry the tooth on the low incisor where the dentine is exposed, and you place 5 layers of soother onto the tooth, and you air dry again. So what Vishali has said is no sensitivity before whitening, and now they have sensitivity. So as I mentioned, those patients who've got the cracks on the low incisor, they're bruxing on the teeth, they need a bite plate. Post-whitening, you can cover over those exposed areas with composite. If you're going to do composite restoration, what you need to do is wait 2 weeks after whitening before you do any composite restorations. Mona, there's a question here. As I understand, we should do non-vital bleaching for cracked teeth. Tooth could be cracked but vital. Okay, so as I mentioned, here we have, let's say we have a patient who has pain on biting, sensitivity to cold, and they want to whiten their teeth. You need to take a radiograph and see what's going. Let's talk about an upper premolar tooth where the patient has got a fracture, the cracked palatal cusp. You need to remove the restoration, evaluate what's going on, place either an onlay or do a special, do a composite restoration, bond it, adjust the occlusion. Maybe the patient needs an onlay, inlay, or a crown, or you do a temporary crown and then you do the whitening. But we need to really monitor carefully those situations, make sure that the pain has gone away with especially the cracked tooth prior to do whitening. Now, some patients who bruxes have got loads of little tiny cracks. That's what we were talking on earlier, and that needs to be monitored as well, because I have noticed on 2 bruxing patients in the last 20 years, we did whitening, they were still bruxing, and we needed endo later. The research has shown on a 17-year study, about 3% of those bruxers might need root canal treatments. So we need to assess that carefully for the patients. Now, there is a question from Mona. How would you match the shade if you need to do the restoration first? I would use a light restoration. If I'm doing, let's say I'm doing a class 5 restoration to reduce sensitivity, I use resin modified glass ionomer. I use an A1 shade on the gingival cervical area. So I'd use the lightest restoration, quite a light composite, and then match it. Most of the time, we like to do it afterwards. Another question, Mona, is that we do is like this. If we're going to do whitening, we say to the patient, Mrs. Jones, are you in the next 5 years considering whitening of your teeth? Prior to, we're about to place a crown on your tooth, on your upper premolar, we're about to place a crown. Are you in the next 5 years considering whitening? Did you ever want to whiten your teeth? Because if you do, now is the time we need to do the whitening first, then we can match the crown to the new shade. That's really key. Let me just see. So now I want to answer the other questions. Okay, we mentioned OPG. Can we access the slides. We don't normally give you the slides, but we've got all the articles. If you go onto my website, you just download all of those. There's no screen now. Have you seen the screens? I think, yeah, we are just chatting now. Another question from Mona. How would you match the, okay, we've done that. Any other question? Let me just check that I've answered all the questions. I hope you can see the slides. Okay. Is there any other questions? Great. I think we are done. I think we've covered everything, Louise. Can you look on the chat to see if there's any other questions? But I think we are done. I just say thank you very much.
I think, yeah, that's great.
Okay.
Well, yeah. Obviously, if anyone's got any more questions, they can email them over to myself or to you, and I can, if they come to me, I can direct them to you, Linda. Is that okay?
Yeah, absolutely. That's absolutely fine. Thank you so much. And we have another webinar we can carry on answering. I think it's on Thursday on tooth wear and on whitening with tooth waste. So I hope that's been helpful. And there was one more question, which was about decision making between brands. Most of the brands are absolutely fine that we use professionally. They're absolutely fine. So I'm going to say bye from me, and thanks very much for the invitation to provide the information. And I look forward to seeing you soon. Thank you so much.